Welcome to The Gut Show. I'm your host, Erin Judge, registered dietitian and founder of Gutivate. I'm also your fellow IBS warrior. Our goal on this side of the internet is to empower those with IBS and digestive disorders to understand their gut better, to have a healthier relationship with their bodies, and to make confident choices to improve their digestive health. During this season, you can expect a conversation around a hot topic related to gut health, digestion, and IBS. As a disclaimer, I am a dietitian, but I am not your dietitian. So everything covered in this episode is meant to be educational and is purely information that you can take back to your healthcare team in order to make the best decisions for you. If you're new here and something just doesn't feel right in your gut, if your symptoms have led you to this podcast, I invite you to start by taking the quiz, What's Your Poop Personality? Your personality type will unveil what your symptoms may mean, what may be causing them, and what you can do about them. This is a free quiz and you can take it today at gutivate.com or find the direct link below in the show notes. While you're going to take the quiz, let's jump into today's episode. Now for a quick word from our sponsors with resources that might support you. Is a gluten-free diet just not cutting it, or maybe not even necessary when it comes to chronic symptoms like bloating, gas, and pain? Research actually shows that in those without celiac disease, it's actually the FODMAP, the carbohydrate, fructan, in wheat, not gluten, that causes symptoms most often. This means that you may not need a strict gluten-free diet to see symptom relief. And it means that if you are reacting to fructans, there may be more foods in your diet beyond wheat that are causing you symptoms. This includes foods like garlic and onion, and even some fruits and vegetables that can sneak their way into your diet and contribute to those chronic symptoms. You can choose to limit these foods and reduce your overall fructan intake in order to avoid symptoms. You also have the option to break the fructan down using FODzyme, an enzyme blend that targets fructan, lactose, and GOS FODMAPs, and that will help you break these FODMAPs down to then prevent the symptoms. Learn more about FODzyme in the show notes, and you can use the code THEGUTSHOW for 20% off your first order. Did you know that you can now order your own gut health tests without waiting months for a doctor's appointment? Gemelli Biotech offers trusted, science-backed, at-home tests for conditions like SIBO, EMO, ISO, and post-infectious IBS. Their Trio Smart Breath test measures the three key gases, hydrogen, methane, and hydrogen sulfide, to detect different forms of microbial overgrowth. As for those with IBS symptoms, IBS Smart is a simple blood test that can confirm post-infectious IBS with clinical accuracy. Validated by the leaders in gut health, these are tests that you can trust and tests that you can take comfortably from your home. So go to getgutanswers.com to find out which tests are right for you and use the code ErinJudge25, all one word, ErinJudge25, to save $25 on your order. And now let's get back to the show. Welcome back to The Gut Show. I'm so excited to be joined by Dr. Zach Spiritos. I think I did not check how to say your name, Spiritos, who I discovered on Instagram. We met online. However, he is a phenomenal voice in the IBS space, in the GI space, and I'm very excited to bring him directly to you guys for this conversation. So Zach, thank you for being here. And I would love for you to quickly just introduce yourself. Who are you? What is your background? What do you do?
I just told Erin that I'm very uncomfortable talking about myself, so I'm glad she led with this first question, just to really start this out in an uncomfortable note, because I'm very awkward talking about myself. But in any event, so I'm a GI doctor. I trained at Duke, so I'm in the North Carolina area. I am a neurogastroenterologist, so we focus a lot on motility issues, sensory issues. I describe it to my patients as more of a software than a hardware problem. So when you have the endoscopies and the CT scans, they all come back normal, right? The radiologist writes unremarkable, or the GI doctor, when you wake up from your anesthesia, says, hey, great news. The stomach looked great. The colon looked great. And you're like, goodness, why do I feel terrible? And that's where you typically fall into my lap. And we talk about some other issues that could potentially be causing a lot of the symptomology that you're facing.
Amazing. And I love that you brought that up with the neurogastroenterology, because I do think a lot of patients in the IBS space, a big problem they run into is that some of the best GI doctors that are out there, some of the ones that are on the cutting edge and the ones that maybe are most renowned in the different states or the different health centers that are available tend to focus on IBD, inflammatory bowel disease. And there's not a lot of people that tend to focus on care for, and we're saying IBS population, functional GI disorders, this kind of what you mentioned, the software side of the GI space. What led you to be more interested in this side versus the IBD side? Like, why did you decide to get into this area of care?
I mean, I think neurogastroenterology is brilliant. It's so much fun, and you get to wear all sorts of different hats. And so you realize that the GI system is a lot more elegant than what we see on endoscopy, right? You see the mucosa, but there's nerves, there's muscles, there's a coordination between that and your central nervous system, and all these things play a role in how not only our GI tract moves, but how we feel it. So it allows me to talk about diet and exercise and sleep and stress and trauma. And me personally, like I think your mess becomes your mission at some point, and I have dealt with by no one's surprise, I dealt with a panic disorder that I developed during medical school and medical training, and I think just a lot of coffee and not a lot of sleep and led to that. And then I dealt with my own issues for a while, and I know how that affects your body. And I think if you're not taking into consideration the mental health piece of things, whether that's how it relates to your GI tract or cardiovascular health, you're missing the piece. Like there's, we've uh, the brain and body is not dual. They're not split. They're intertwined. And if you're not focused on both, you're kind of missing the boat a little bit. And it gives me the opportunity to touch on those things. Not only, how does your poop look, but how's your sleep last night? Like, how are your relationships right now? How often do you get outside? How often can you exercise? And we get to talk about all these lifestyle pieces that really have a humongous impact on how the GI system moves and how we perceive our own GI system. So it's a lot of fun.
Yeah, I agree completely. I tell people all the time, I have an IBS background myself, unfortunately, and that's why I got into the space too. But there's also a lot of joy I find in the IBS surrounding space of the creativity involved and the puzzle piecing of it. As a practitioner, it's really fun to like put puzzle pieces together. And then even working with patients where can't always say, oh, here's your treatment, step one, step two, step three, it's going to work that way perfectly. But being able to see people, go do the things that they love and get some of that confidence back and, develop a life that really supports their symptoms, but also supports every other part of their life, not just their condition, is really rewarding. And I'm sure you feel the same way when you get
I'm
to.
treating them. I'm not treating your
Yeah.
colon, right? And I get to understand who you are as a person, and it makes our relationship deeper and more profound. And yeah, I think it enables you to treat the whole person rather than just enabling them to have a Bristol stool, just a Bristol scale 4 stool, which is not the key to happiness. It is a key to
Yeah.
better health, but not the key to
Poop
happiness.
is not the key to happiness. I think we should make sure to say poop is the key to happiness.
It's part of it. It's part of it. But
Part of it. Well, we could talk about this all day. That is not actually why I brought you in, but because of your content online, I can tell that you talk to patients directly and you bring solutions to the table for things that I think a lot of patients have not always gotten solutions for or gotten ideas for. They felt a bit dismissed. You seem to do that in your content where you bring the solutions, you bring ideas, you bring some creativity, you think outside of the box. So I wanted to cover some of that of why, because everyone has a story in that. But I do want to shift a little bit to get to one of the topics that you do talk about fairly often that is really important. I think we're at we mentioned this when we were preparing this episode, we're at the cornerstone, I think, of this being the biggest topic in the IBS space, and that is mast cells. So before we get into it too deeply, what are mast cells?
mast cells are these cells that are really helpful for us. They're in us for a reason. They are an innate part of our allergic system and our immune system. And they do a lot of amazing things. They provide defense against viruses, bacteria, parasites. They help fortify our gut lining. They help with wound healing. They're a first line of defense in kind of allergic exposures, and they're quite wonderful. But when they start to get a little twitchy and overactive, that's where they start becoming they start to hinder our health and can affect us negatively in many, many ways.
Amazing. And what does that mean whenever they are not functioning properly? Does that mean an autoimmune condition? Like what is that exactly? Like what are they doing?
Yeah, so it's more of like an immunologic phenomenon. I wouldn't say it's an autoimmune condition. So these mast cells become very twitchy. So mast cells have about 1,300 chemical mediators in there that do all sorts of amazing things typically. I kind of think of them as the neighborhood watch, right? So they're wonderful when they call you when your garage is open or there's someone sketchy lingering outside your home. But once they start calling you because they didn't like the shirt that you wore yesterday or there's a squirrel on your porch, you're like, they're becoming annoying. So in mast cell activation syndrome, these mast cells become very twitchy. And instead of being activated intentionally, they become activated at the drop of a hat. So not only when there is a bacteria being introduced to your system, but when you ate something that you shouldn't have, um, or you felt a certain emotion, or you didn't get enough sleep, or you went to too high an elevation, or goodness, there's a litany of different triggers out there. And so these people are living in this world where they're constantly being bombarded by seemingly innocuous things. And these things then trigger mast cells to degranulate or secrete all of these chemical mediators, causing a whole lot of issues.
What are some of those issues? Are those, now we've talked about as if it's immune, are those only immune symptoms or does it depend on where the mast cells are? Like what types of symptoms would someone experience when these mast cells are breaking down?
Okay, great question. So I think we start the conversation by examining where mast cells exist. And the unfortunate answer is everywhere. Our skin, our lungs, our upper respiratory tract, our GI tract, our brain, our cardiovascular system, everywhere. Okay. And the reason why I treat this, I am not an allergist by any means, but I tend to treat a lot of folks with quote unquote IBS, which effectively means they've seen another GI doctor or two or three other GI doctors, and they've had the entire workup. They've tried a bunch of therapies and they still feel pretty crummy. So they come to me with refractory heartburn, bloating, diarrhea, constipation, but then they also have a whole host of other symptoms. In fact, I haven't crunched these numbers, but I would say 8 out of every 10 patients who I see for refractory IBS, and my colleagues send them to me or they come to me from elsewhere, have a mast cell disorder. And so if you dig a little deeper and expand your scope to beyond the GI tract, you realize that, goodness, they also have brain fog and headaches and migraines and palpitations. And they itch all over for no reason. They get random rashes. They're sensitive to all sorts of different things. And they also sometimes have dysautonomia, like POTS, or they're really bendy and flexible and have a hypermobile disorder. And so once you start digging a little deeper, you realize that the GI system may be the most prominent symptom, but it exists in this world of a whole host of other symptoms that are really driving these people nuts. And so the classic patient that I see is a young woman who has about 6 doctors, a neurologist for migraines, a GI doctor for IBS, a cardiologist for palpitations, an allergist, an OBGYN because they tend to have a lot of dysfunctional uterine bleeding because one of the chemical mediators that mast cells secrete is histamine, or I'm sorry, not histamine is one of them, but heparin. And so, yeah, it affects everything. So once you zoom out and realize this is not just a GI thing, but they're living with all these other conditions, but all these other conditions aren't necessarily sufficient or bothersome enough to tell to a provider. Because they're like, oh yeah, I itch a lot, but goodness, that doesn't bother me that much. Or yeah, I deal with headaches on a, somewhat regular basis, but it's not enough to really, I call it a work. So it's in the background of all these other kind of white noise of issues. And they don't, I met with a young female today and she goes, I cut myself and it takes me like a year to heal. And these little things that don't amount to an ICD-10 code or enough to see your doctor about, but you ask them, you realize that their body just behaves differently than other folks.
Amazing. And there's a million directions we can go. I think before we get too deeply into like treatment and some of those conversations, I want to talk a little bit more about the IBS mast cell piece and then the MCAS piece. So I think you're on the front of this, and you mentioned before we got on about there's a guideline now on MCAS. I think a lot of patients are learning about MCAS and learning about mast cells as a whole, but having a difficulty getting the right diagnosis. And it's almost like they hit the other wall of, well, I'm not sick, I'm not enough to be even MCAS. So then can mast cells even be at play? And there is a conversation in the IBS space. This is something that Dr. William Che out of University of Michigan was presenting on recently, but talking about how the post-infectious IBS piece and that low-grade inflammation piece of IBS, that there are identified mast cells. And we've seen some, right, where like, I think IBS-D, like there are more mast cells present. How active they are in the diarrhea, we don't know, but like they're there. And when there is maybe an infection, like mast cells recruit other mast cells, and could too many of them and their like recruitment cause them to break down? Is inflammation involved? So I know there's this big conversation of that subset of IBS patients, like, and how do we tell, all that stuff. But then there's this gap between this IBS, mast cells are involved, but do you have MCAS? So I'd love for
It's
you to
nuts.
address
It
this
makes
part.
no sense. Makes no sense. All right. So this is how I make sense of it. This is how I think about it in my brain. Okay. So what is IBS? IBS is a collection of symptoms, right? So it's the cardinal symptom is pain. Okay. So you need to have pain, constipation, diarrhea for a prolonged period of time. Okay. What is the scientific underpinnings of IBS? It is heterogeneous. Not everybody's IBS is the same. So we think it's a combination of dysbiosis or an altered intestinal microbiome, increased intestinal permeability or leaky gut, and visceral hypersensitivity. But how do we get there, right? Everybody's journey to IBS is different. So when I talk to my patients, the first thing I ask them is, when's the last time you felt normal? Because that really helps me identify like how this all started. Was it a humongous infection? I think that's categorically different than MCAS. I do. I think mast cells in that situation could be an epiphenomenon or just a byproduct of the inflammation there. But I think MCAS is a way you get to that disrupted microbiome, increased intestinal permeability. Like mast cells also secrete proteases, which break down the intestinal lining, okay, and can lead to increased intestinal permeability. And then some of these other chemical mediators, like they secrete cytokines, which bring about more inflammation. They also secrete histamine, which can lead to visceral hypersensitivity in the pain element. The question is I think my goal with every IBS patient is to identify why you had your IBS. Is it post-infectious? Because there are categorically different treatments for that phenotype. Is this dysbiosis from years worth of antibiotic use coupled with childhood trauma? Or is this a mast cell mediated event? And so are the mast cells that we find on biopsies in IBS indicative of mast cell dysfunction and mast cell activation syndrome? Not necessarily. I think if you have GI symptoms coupled with symptoms all over the place, that's where I start exploring, is this mast cell activation syndrome and causing IBS type symptoms as opposed to a different flavor of IBS?
That's great. And so the thinking about like a treatment approach, it would be maybe mast cells could be addressed in some of those cases temporarily as other things are being addressed, versus like in a mast cell disorder, the mast cell treatment is like the kind of underlying chronic treatment that's at play. Is that a good like summary?
I think you just have to understand why your IBS happened. And then I think the treatment is specific to you. So if I have my classic IBS patients that their symptoms are pretty much localized to the gastrointestinal tract, that is not someone where I would focus on treating their mast cells because I just don't think it's going to work. It may work because I also believe that mast cell activation syndrome is a spectrum, and we're just learning about this. So what happens, there are, and I imagine there are probably patients out there that have been mislabeled as who have IBS and have some really subtle other symptoms, but goodness, their symptoms are primarily in the GI tract, and they may respond to mast cell mediated therapy. But what really kind of perks my ears for a mast cell disorder is symptoms kind of all over the place. Neurologic symptoms, cardiovascular symptoms, dermatologic symptoms, and they end up in my lab because they have predominant GI symptoms as well.
Great. That's a great overview. And I think the complexities of it all are so fascinating. I'm very interested in this just because I think with the SIBO, stuff that we've learned and like certain pathogens, and there's just so much room to explore what all is going on and being able to possibly manipulate all these factors in the gut. Like maybe we can't, maybe we can, I don't know, but it's very interesting as a patient and also as a provider in some of these cases where it feels like we keep hitting a wall. Like where is that wall? Where else do we go? Before we do get into the treatment and like what that looks like, the question has to be, well, why do patients end up with mast cell activation syndrome? Is it genetic? Like, is there a trigger like autoimmune? Like, is it similar in that way that there's like this trigger? Like, what is going on to even lead to that
to then be an underlying cause of what else is happening?
Yeah, that's a really good question. And every time I have an MCAS patient, I try to phenotype them as well to understand why they develop mast cell activation syndrome. So some of these patients, so there is typically a lot of background noise. I think I used that term before, but in their childhood, like childhood allergies, eczema, food intolerances, like your tummy hurts a lot, you can't sleep, like all these little things that don't amount to any specific diagnosis, and something happens. Is that puberty? This just disproportionately affects women. We know estrogen can activate and kind of in turn make those mast cells degranulate. Whereas testosterone is more of a protector and actually is a mast cell stabilizer. So is estrogen playing a role there? I have a cohort of patients who, after pregnancy, develop mast cell activation syndrome. And I think the big reason why we're seeing so much of it these days is COVID and the COVID vaccine, but also other vaccines like the shingles vaccine. So the data would say that there's a higher rate of getting this after COVID, the virus itself, but certainly vaccinations, and not just the COVID vaccine, but I've seen it after shingles as well, can trigger this immunologic phenomenon where your mast cells become very twitchy. There is an autoimmune component as well. So I have patients that have an autoimmune phenotype. They also have Sjogren's and they have Graves' disease. And so they have more of an autoimmune milieu and they kind of start to spill out a lot of these autoimmune antibodies. So one of my initial kind of tasks is not only to make people feel better, but also characterize their MCAS because it does have an implication for how we treat you down the road. And also can tell you like, are you at risk for developing dysautonomia or other autoimmune conditions? So I try to stratify each person when I first meet them.
That's wonderful. So now looking at treatment. So, well, I guess no, we have to talk about evaluation, right? So there's even the step before treatment is great. My symptoms line up. Here's what's going on. Like this makes sense. My history has been taken. Are there tests that can be done? Are there tests that are trusted? Are there misconceptions out there about tests that are available in the evaluation before you can even get to the treatment side?
Yeah, testing is lousy. It is. So there is I think the traditional teaching has been order a tryptase value. And the tryptase is one of the markers that mast cells secrete. That said, it's not very sensitive. In fact, not many folks will have an elevated tryptase value. And the old guidelines would suggest that you obtain this value when you're having an attack. And like, who's waiting by a lab when they have an attack? Like, that's just not reasonable. So not much value there. There are new consensus 2 guidelines that incorporate other lab tests into the kind of diagnostic criteria for mast cell activation syndrome. And there are urinary markers, there's specific 24-hour urine collection tests that allow us to detect elevated levels of mast cell modulators, or some of the chemical compounds that mast cells secrete. And with those, and they are commercially available, you can order them at big institutions. I believe LabCorp has them. The Mayo has them as well if you send them up to Mayo. And that sensitivity gets around 50%. So it's a coin toss. So still not fantastic. The beauty is that the diagnostic criteria, it's kind of a 3-legged stool, and that is one of the legs, but the other leg is response to therapy. So if I have a clinical hunch for it, which means that you present with mast cell activation syndrome like symptoms, and I can't attribute those symptoms to anything else. And quite frankly, what causes all of these symptoms? Not a whole lot. But that's where like a lot of patients, I'll kind of dovetail a little bit here, that a lot of patients get told that it's anxiety or stress because anxiety can theoretically cause palpitations and brain fog and just kind of a whole host of other quote unquote psychosomatic symptoms, which by the way, I hate that word. But yeah, so a lot, I think before we knew more and more about this condition, a lot of folks were kind of put in that box, but you talk to them and they're like, I am not anxious. I live a wonderful life. I just can't think and my heart races. But beyond that, I feel pretty good. Like I'm fairly well adjusted. So they will tell you I'm not anxious, but they keep being prescribed SSRIs, which is obviously very frustrating. But so what I will do is if I can't attribute your symptoms to anything else, which rarely I can do, we will order the tests, but quite frankly, I don't care what the testing shows. And then we'll start therapy. And there are like 20 different mast cell stabilizing agents out there. And I think everybody who is savvy with this illness has their own algorithm. And there's no FDA approved medication for mast cell activation syndrome. So everything is used off label. I start with H1 blockers and H2 blockers. So the former are traditionally allergy medications like Zyrtec, Claritin, etc. And the latter are H2 blockers, which are commonly known as Pepcid or famotidine, which is used for gastroesophageal reflux disease. We use really high doses of it, and quite frankly, it is really, really safe. So we start there as a proof of concept to see if you get better. And then we start layering therapies after that. There is a very pertinent question that people ask me is like, is this forever? And my answer is, I don't know. I really don't. There's not enough data around this. So what I always do is we say, okay, let's get you on medications, just get you feeling better. And we always couple this with a really deep dive into your triggers. Is it, there's data that mold can do it, right? Is it something you're eating? Is it a perfume? Is it a shampoo? Is it stress? So we have to dive into all those things, and a really diligent symptom diary helps us kind of connect the dots. And that's the big picture. Like that's what we really, really want to achieve long term. But in the immediate setting, goodness, let's just get you feeling better.
Now for a quick word from our sponsors with resources that might support you. Are you struggling with bloating, constipation, or diarrhea, and you're still waiting to see your doctor?
Take control and get answers with Gemelli Biotech's at-home gut health tests.
The Trio Smart Breath Test is the only at-home test that is validated to look for all 3 gases that are associated with microbial overgrowth: hydrogen, methane, and hydrogen sulfide. That means it can detect SIBO, EMO, and ISO in one simple test. It ships right to your door, no appointment needed. You take it and you send it back, then you get answers. If your IBS symptoms started after a stomach bug or food poisoning, it could be post-infectious IBS. The IBS Smart Blood Test is a quick at-home test to help identify it. Fun fact, 1 in 9 people who get food poisoning will end up with post-infectious IBS, and most don't even know they have it.
With both of Gemelli Biotech's tests,
You'll get clinically backed results in about a week, and you can take them straight to your provider. No waiting, no referrals, just answers. Find out which tests are right for you at getgutanswers.com and use the code AaronJudge25, all one word, AaronJudge25, to save $25 on your order. You can also find all these details in your show notes.
as someone with IBS-C, I've struggled with symptoms related to food for the majority of my life, specifically FODMAPs. My personal triggers, beans, dairy products, garlic, and onion, would leave me feeling bloated and uncomfortable after meals, especially whenever I was eating out or traveling or living my life outside of my home, which meant I either had to just deal with the symptoms or eat bland, awful food and miss out on experiencing the social interactions and the joy of food. Finding FODzyme was a game changer for me. This is an enzyme blend that targets FODMAPs, specifically the GOS that's found in beans, fructan in the garlic, onion, wheat, and even different fruits and vegetables, as well as lactose in dairy products. I stash this in my wallet, my husband's wallet, every bag I own. I take it with me everywhere I go so that I can simply sprinkle it on my meals, eat with confidence, and feel my best after. If you want to try FODzyme for yourself, go to FODzyme.com and don't forget to use the code THEGUTSHOW, all one word, THEGUTSHOW, for 20% off your first order.
Are you taking a prescription medicine for irritable bowel syndrome with constipation or IBS-C? If symptoms like constipation, belly pain, and bloating are still bothering you, it may be time to try something different. Ibsrela, tenapanor, is a prescription medicine used to treat adults with IBS-C. Ibsrela works differently to relieve the symptoms of IBS-C so that you can focus on what's important to you. Ask your doctor if Ibsrela could be right for you. Do not give Ibsrela to children less than 6 years of age. You should not give Ibsrela to children 6 to less than 18 years. It may harm them. The most common side effect is diarrhea, sometimes severe, and your child could get severe dehydration. Stop taking Ibsrela and call your doctor if you develop severe diarrhea. Do not take Ibsrela if you have a bowel blockage. Tell your doctor if you are pregnant or breastfeeding and about the medicines you take. Other common side effects include swelling or a feeling of fullness or pressure in your abdomen, gas, or dizziness. Learn more at ibsrela.com/PI or call 1-844-IBSRELA and press option 4. Ready to try something different for your IBS-C symptoms? Ask your doctor about Ibsrela.
And now let's get back to the show.
And when you talk about these medications, you said like mast cell stabilizers, just a breakdown, because I think a patient may see that and be like, well, I don't have primarily reflux. Like, why would that, right? We try to pigeonhole ourselves. Like, why would that work? What do these medications actually do?
So they stabilize the mast cells from degranulating, and they also can help block some of the chemical mediators that the mast cell secretes. So for example, I have a lot of patients with refractory reflux disease. So this is So I don't want to get into this because this may resonate with a lot of people because I have a lot of patients have entered my clinic with this symptom where they eat a tomato and they have reflux for like 2 straight days. Or it's a thin, otherwise healthy person who has rip-roaring reflux. And that just doesn't happen. Like reflux has to happen for a reason. There has to be a reason why your lower esophageal sphincter is dysfunctional. Either, you carry a lot of excess weight or you have a hiatal hernia, all of which traditionally does not happen to young, healthy people. There are exceptions, obviously. But you have all these folks who just have no reason to have reflux disease, and it will persist for days on end. And you're like, and it's not responding to any reflux medications like omeprazole, which by the way is a really good medication. So if you have reflux and you're taking omeprazole and it's not working, it's probably because you don't have reflux disease. And so the reason that happens is chemosensitivity to these mast cells degranulating. So these mast cells degranulate, and there's a huge histamine surge. And what histamine does is it releases a lot of acid. That's so much so that it can overcome a PPI. But that also just the mast cells themselves degranulating have an irritating effect on the lining of the esophagus and stomach. And so that's how that happens. So yeah, so Zyrtec or H1 blockers and Pepcid like H2 blockers help stabilize the mast cells so they don't secrete as much of their chemotoxins and also help block the downstream effects of histamine, which is one of the main drivers of a lot of symptoms in mast cell activation syndrome. So palpitations, brain fog, fatigue, flushing, itching, rashes. Like I had a young patient maybe 2 weeks ago who's had like 6 colonoscopies, MR enterographies, video capsule studies, was put on empirically Stelara for Crohn's disease. And she gave a great story for mast cell. And we put her on Pepcid and Zyrtec, and in a week, she goes, my symptoms are all gone. That is not common. That doesn't happen a lot. It is usually a layering philosophy where we touch base every 2 weeks. So I say, we're going to start something. 100% this is trial and error. I'm telling you this is really challenging. I wish this wasn't. I wish I could punch in your height, your birth date, your favorite color, your name, and like we know exactly what to give you, and that's just not the reality of this. So it's trial and error.
Which is great for people to know. I've definitely had patients who have worked with different like immunologists or allergists that maybe aren't as familiar with mast cell activation, but are willing to do some therapies. And if some don't work fully, I do see the patient side sometimes where they're like, well, that didn't really work. And then there's not a follow-up. And so that's a good reminder for patients of it may not be that didn't work, but the follow-up itself and like the teamwork aspect is needed, which is a good marker to find the right doctor that will work with you as a team. You mentioned histamine, and I think in the functional medicine space, on the social media space, we see a lot about histamine. What's the difference between histamine intolerance and mast cell activation syndrome? Like, are they the same? Is there a difference? And should histamine be the thing that's looked at too quickly, or should we be looking at mast cells first?
Okay, so let's break down what histamine intolerance is. So what happens after consuming something that is high in histamine that your body is not able to properly break down. So we have these enzymes along the line of the intestines that help break down histamine, which is biochemically active and can cause symptoms, to histidine, which is biochemically inactive and can't cause any symptoms. So when you eat something high in histamine, whether it's aged cheeses or wine or pepperoni, really anything on the charcuterie board, which stinks because we love charcuterie, or leftovers. Leftovers have a high histamine load as well. That when you eat that, soon afterwards, 30 minutes to 3 hours later, you can develop a whole host of symptoms, which is in contrast to mast cell activation syndrome, which quite frankly, you can get symptoms independent of eating because those triggers aren't necessarily related to eating. It could be stress, it could be sleep, but there are variants of MCAS where people really only have symptoms after eating. And so it's tough to know, is that histamine intolerance or is that mast cell activation syndrome that is just a reaction to a certain food? And that's a little tricky there because histamine intolerance can also have multi-system or kind of systemic symptoms like flushing, brain fog, fatigue, palpitations, etc. So one clue to know what is this postprandial or not? Is this only related to mealtime, or is it quite frankly really, really random? And so unfortunately, there's not, Histamine intolerance will not have those chemical mediators of MCAS show up on testing. So if you have positive testing for MCAS, it's not going to be histamine intolerance. But I think the 100-foot view, the Cliff Notes version of this is if it's not immediately after eating, it's probably MCAS. If it's after eating, it could be an MCAS variant or more likely histamine intolerance.
Great. And then when we look at histamine intolerance, that's where we do like maybe a low histamine diet or decreasing intake that can help, right? Maybe breaking it down, antihistamines, things like that may help there, but those may not touch MCAS fully. They might sort of help if they're like helping with the histamine release, but that's only one factor. So that could also be a red flag if you're kind of treating your histamine intolerance and having symptoms outside of that and not really seeing the benefits. Do you find that people with MCAS, because this is the question as a dietitian that I get asked a lot, when they're treated properly, you know, we're aware of the triggers. Do you think they need to be on a low histamine diet forever? Or do you find that some patients, when they're treated well, actually can eat histamines? Maybe you address that separately and it's not such a big deal since that's not necessarily the main problem.
I think you have to meet the patient where they are. And so in Mast Cell Activation Syndrome, I really don't think the histamine diet is going to help a whole heck of a lot. You can try it, and if you find that you have a significant benefit with it, fantastic. Like we can certainly press that button, and it's great because it's another tool that we can exercise. In histamine intolerance, I think it's probably pretty crucial to the treatment. That said, they will also respond to H1 and H2 blockers. And so it all depends on who they are. Like there are several conditions in GI, like eosinophilic esophagitis, where there's a diet component. Like if you follow this diet, we can get you under control. But goodness, the diet stinks. It is just really restrictive. Similarly, the histamine diet is a real pain. Leftovers, you have to just manage them so carefully. You have to watch everything that you're eating. And so I think it all depends on how motivated a person is to come off the medication. So it's all a risk benefit there.
I like that. And I see it on the patient side a lot. And I will agree. I think someone who's really trying to like avoid high histamine foods and avoid the leftover side and avoid histamine liberators and like across the board, it does get tricky. And I will say patients who even know those are triggers, they follow it to a T, never veer from it. And they don't always have 100% success either. But are sometimes hesitant or just don't have the right resources to get the right treatments,
Yeah.
which is,
I
think, the problem.
Yeah. And I think that these folks are often very in tune with their body and keep a very good symptom diary. I learn from patients all the time in this world because they're so smart and so on top of it and detail oriented and come with these huge symptom logs. And they've already cut out so many foods that then you can get into ARFID, which is a avoidant restrictive food intake disorder, which is really has a really significant impact on quality of life and increases anxiety levels and stress levels. And probably if that leads to stress, can impact your MCAS in some weird indirect way. So I think that the more I could liberalize your diet and get you feeling great, perfect. So I will always hit symptoms really hard with medications. I think of it as stabilizing a bike that's just a little bit wobbly. You put some training wheels on, and this is the initial phase one is diagnosing you, getting you to feel good about yourself, that you can wake up and feel confident you're not going to have symptoms, and then we can untangle the diet later, unless you're motivated to not be on medications. But again, you got to meet a patient where they are and understand what their goals are before initiating a treatment plan.
Yeah, great point. Great reminder. Now for patients so people listening, and I agree 100%, I think patients are very wise in this space, in the IBS umbrella space. Most patients are very type A. I get that. I'm the same way, but they've done their research. They've gotten all the information they can. They're usually the ones guiding conversations with the doctor. They know what's the latest news and they're willing to talk about it and they're ready for whatever test they can get offered. Like patients are ready, patients are informed, which I love. The downside is sometimes patients don't know where to take that information and find a provider. And even as a provider, trying to find the right provider to even assess MCAS, I will say that is one of the hardest parts of my job is figuring out, do we go to allergy? Do we go to immunology? Can we get this through your GI? And then patients, even within those providers, tend to get the runaround. So do you have, I know, like, we'll talk about you and like your clinic and if that's an option, but that's not going to be available to everyone everywhere. So do you have advice for people who are searching of like things that they can look for or questions they can ask on the front end to kind of weed that out more?
Yeah, I think reliably or the most I think if I were in the community looking for MCAS help, I'd call my local university center and I'd start with allergy, pulmonology, and see where that gets you and see, are there any providers here that are savvy with MCAS? Unfortunately, they're probably gonna be booked out for a couple years though, because there's not many of them and there's so many patients with MCAS. And that's where I would start, is the university centers. But we weren't taught this. Like, I wasn't in medical school that long ago. I've only been, I did GI training, residency. I've been in attending for 4 years. So it's probably been, goodness, a little over a decade. So I don't know if even the books have had time to be rewritten, but MCAS didn't come up a single freaking time. And it didn't come up in GI fellowship either. And I'm seeing 4 to 5 patients a day with MCAS. And so it is really tough. It's a struggle out there. I don't know if I have a really good answer there, unfortunately. I'm just hopeful that, as we push information out there, that a lot of providers will start educating themselves and understanding that once you start paying attention to this, you'll start connecting the dots for a lot of these patients. And they won't have to go to a million subspecialists. You'll be able to identify up front, hey, this is what's going on. And maybe we get the opinion of a subspecialist just to make sure we're not missing anything. But a trial of an H1 and H2 blocker is a pretty benign entity. And it is a putative diagnosis a lot of times, where we're kind of working on gestalt. But if you can, in medicine, we talk about a differential diagnosis. So you say, what is the leading cause of what's going on? And what's B, C, D, and E in case number one doesn't pan out? And if you can tell me one thing that acts as a common denominator for all of these issues, and is it statistically likely that one young person or one person has tachycardia, migraines, dysfunctional uterine bleeding, IBS? Like, that'd be so unique. And I found that, incidentally, I started doing the social media thing last year, and a lot of people are like, goodness, I'm seeing this now a lot. And now I'm just looking for good tools to educate myself. And that's where I think the powers that be are working on creating better guidelines, better treatment guidelines. And the diagnostics are getting there, certainly imperfect. Where we're lacking are treatments, because everything is borrowed from a different condition. And we're kind of making it up. Like, I have my own algorithm. I also talk to a lot of the people that have been in the MCAS world for a while, and they're kind of mentoring me, so to speak. So I learn a lot from them, and I ask a lot of questions, and I listen, and I read a lot. But everybody has their own algorithm, because there's nothing that has been studied, and certainly really any scientific capacity, like a randomized control trial, to say that it works for MCAS. So a lot of it's anecdotal. But I will say, in personal experience, as someone who sees refractory IBS all day long, treating MCAS really works.
That's great. And then what advice would you give to a patient? So being directed to the patient that hears you and is hopeful, at the same time, there's that part of them that is thinking, well, will I ever know if that treatment is safe then? Or how do I know definitively that it is this? Like, that kind of, not second guessing part, but just sort of the gray area that exists because of where we are in time right now. What would you say to that patient?
I always embrace the ambiguity, right? Because it's not perfect. It's messy. And so is IBS. IBS is messy, right? And so this isn't a broken ankle or a pneumonia where we say, okay, we're going to brace this ankle, we're going to do surgery, or we're going to put you on this antibiotic, you're going to get better. Like, there's a lot of unknowns here. So you have to embrace it. And that's scary. But you have to have a doctor that works with you. This is not a one-way street. I always work with my patients. This is a partnership, right? Because if you're not telling me what's going on, I can't do my job. There is no lab work to dictate what I should do next. This is feel. And I've had a lot of success, but I've also had a lot of patients that we're still working, right? And we've had some gains, but sometimes we haven't. And so we keep plugging away. And there always has to be a counter, right? So if this doesn't work, this is what we're going to explore next.
That's great.
Yeah. The good news is that a lot of times they've had a lot of the testing before they came to see me. So they've already had the workup for all the other stuff. And what complicates matters is that a lot of these folks often have dysautonomia too, like postural orthostatic tachycardia syndrome or hypermobility, which both of them are also poorly understood, mainly because they affect women. And that's a different conversation for a different day, and how we fundamentally don't really understand women's bodies even to this day. But I can go on about that for another half hour or so.
Yeah. Well, I think everyone listening, for the most part, would say, yep, I totally understand. And I agree with patients. Sometimes it is sitting in there is a lot of discomfort and not knowing for sure. And I think sometimes we are fed lies. We talked about this at the beginning of our approach, even to social media, of I'm very careful myself to not overuse even like root cause language, because I do think patients sometimes there is value. Yes, we have to peel back the layers. Yes, we need to explore. But I think as a patient, sometimes you can get your hope up so much that like, I'm going to find this definitive answer, or like this treatment that's going to be backed by all this research. It's definitively safe. I know exactly how it's going to affect my body. And especially women, this is a fear they have. And when you then get to the end of the road, but it's not the end of the road, and the next step is very scary, it's almost like, well, who do I trust? What do I do? And there's almost like this disappointment that's paired with that hope. And a lot of patients I find don't take action on it because they're too afraid because of that background noise, or they go routes where they do chase the language maybe that isn't actually accurate and end up in a worse position. And then they don't trust anyone again. It's very messy out there. And so I like that you said that. And I do think I tell patients all the time with their doctor, it's like, just ask, what's the next step? What do we do next? What are we looking for? Like, that is collaboration. It may not be definitive, but if you know, okay, there is still a follow-up, or there is a plan that we do next, or there is some communication here, we are partnered here, you're not just leaving me on my own. Like, there's a lot of value and trust that can be built there.
Absolutely. I agree wholeheartedly.
Yeah. Well, you mentioned, so I know everyone hearing is like, well, how do we find people who do the exact work that you do? Because this is very needed. And you mentioned that you started your own clinic, or you're starting your own clinic. Is that in this area specifically of care, or what are you doing? What's your vision with that?
Yeah, so I treat complex GI conditions. So, refractory IBS or IBS, refractory reflux disease, just really challenging, nausea, vomiting, really anything that really hasn't been identified and treated yet. That's kind of the world that I live in, because typically this is a software issue, whether this is a disorder of the brain-gut interaction, or some neurovisceral disorder like porphyria or cyclic vomiting syndrome. And that's the kind of the world that I live in, and I love treating those conditions. As I've been doing this for several years, I have stumbled upon Mast Cell Activation Syndrome, and it's become a humongous part of my clinic. I also realized that a lot of these patients have dysautonomia and POTS, okay? And so I'd get them pooping again, but they can't stand up without getting dizzy. And they're like, I'm not making any difference in these people's lives. And about 2 years ago, I realized that hardly anybody sees POTS out there. So I went to a residency program that really made me a pseudo cardiologist. And so I started asking questions and learning and reading. So I started treating dysautonomia on my own, not only the GI manifestations, but also the cardiovascular implications. So we treat dysautonomia, not only the GI component of things, but also the cardiovascular part of things. I see a lot of patients with hypermobility. This is a telehealth clinic, so we cannot address the musculoskeletal complaints of hypermobility, but we are aware of all the comorbidities of hypermobility. I sent someone for, treatment of craniocervical instability the other day, which is a neurologic phenomenon. So we are aware of all of these issues. Obviously, I'm not seeing these people in person, so it is not a hands-on clinic. We screen for a lot of these issues to get you the treatment that you need. And we tend to know a lot of the players in this field to identify who can take good care of you. So it's a lot of stubborn, hard to treat conditions that are generally poorly understood. We're a telehealth-based clinic because we want to prioritize accessibility for all these folks out there that are kind of in no man's land, putting together their health on their own. So we're in North Carolina and Illinois to start. My partner's in Illinois. He's a weight management physician. So I'm also very passionate about weight management. A lot of GI conditions, weight plays a big role into the manifestation of some of the symptoms. So I am not an expert by any means in weight management. I do not do that, but my partner does. He's amazing. We have a dietitian. We're also creating exercise plans for people with dysautonomia. And so we know that exercise plays a big role into dysautonomia. So we are crafting personal exercise plans. And our dietitian is very savvy in dysautonomia and IBS. And so we're creating this team to help support these folks who have just don't really know where to turn next. And we're hopefully going to expand and broaden our horizon to other states in the coming months to years.
Wonderful. I will link that in the show notes. So if anyone's interested, if you're in those areas, or you want to just follow along so that you can know if things get into your area, or you want to, travel to those areas and live there for a few months. I've seen patients I have patients who live in Canada who come to the US to meet with people and just stay there a few months and do what you've got to do. Patients do what they need. Well, outside of that, how can patients connect with you and continue to learn from you?
You can follow me on Instagram on Dr. Zach Spiritos, and our clinic's name is Ever Better Medicine.
Wonderful. I'll link all of that. But thank you so much, Zach. This was an incredible conversation. I know patients are going to love it, providers as well. I find value from it. I think this is a super exciting area in the GI space, and I look forward to seeing what comes next. And hopefully, you get to help lead the charge since you're in the space and ready and passionate about it.
Thanks for having me, Erin.
Are you listening to today's episode with the main thought being, what are the steps that I can take to get rid of my symptoms right now? While I hope that the information that we share in every episode of The Gut Show leaves you feeling more empowered and more confident in your body, it's not always going to solve your problem or give you a clear direction for your specific symptoms and your needs. The Master Method membership is an online program for the person with chronic digestive symptoms and IBS who wants step-by-step guidance to understand their body, address the drivers of IBS, reduce symptoms, and build resilience in your gut long-term. This membership includes a step-by-step course and a dietitian-led community that teaches you how to holistically address each symptom and the IBS drivers, how to reduce symptoms more strategically and with confidence, and guidelines for better gut health long-term so that you're not only thinking about today, but you're also improving your outcomes in the future. It is time to ditch the symptoms and get your life back. The membership is your first step. You can learn more and enroll at ibsmastermethod.com and use the code GUTSHOW, GUTSHOW, GUTSHOW for $25 off your enrollment fee.